So today I'm going to be talking about sexual function, sexual health, sexual pleasure. And if you were to look in the old family medicine textbooks and you have all your lists of topics, this usually falls under what they used to call sexual disorders. And we now like to call it sexual dysfunction. So we're not talking about sexual health like an STI treatment or pregnancy prevention. We're talking specifically around sexual function. And one of the challenges we have is that quite often you can't talk about sexual dysfunction unless you understand what normal sexual function is. And that sounds pretty simple, but actually in the world of medicine, and even just in the world of science, has been so strongly influenced by cultural things, political things, even religious things, that our understanding of what's sexually normal has changed dramatically just over the last 100 years. So we are getting closer and closer to understanding what healthy sexual function actually should be like. And most of the times when you're having patients who are struggling with sexual relationships or struggling with sex in general, a lot of it has to do with them not understanding normal sexual function. So today we're actually going to be doing a little bit of a training on normal sexual function. And there are some handouts there we're going to be working with in a minute. I do have a few slides on some actual sexual dysfunctions like erectile dysfunction at the end, but I don't even mind if we don't get there, and at least you guys will know your basics. So I attended in August of last year, very excitedly, the World Association of Sexual Health first ever conference in Africa. So Africa is politically always been a sensitive area talking about sex. And when you introduce yourself at the conference, you always give the perspective that you're coming from when you're talking about sex. So the first part of being able to be a sexual health practitioner is understanding who you are and what your perspective is. Because only then are you able to understand, okay, this is where I'm coming from, that is where that person is coming from. So I am a cisgendered, married, heterosexual woman. I've got 2 teenage kids. And my background in sexual health is very much from the sex education side. So we lived in the UK many years ago, and I was very involved there as a school doctor in various types of schools, and very involved with the one school and helping them set up a sex ed curriculum. And then in South Africa, I've been helping with doing school doctoring work, mostly with schools in Durban, Johannesburg, and Cape Town, mostly in training of teachers. So I've got a whole bunch of webinars coming up now in May and June at different schools in other parts of the country, specifically around sex education. So that's always been my interest, is helping people understand sex better. And then since we came back to England in South Africa in 2006, I've been very much involved in the HIV TB world and very much NGO side. And I've always had a special interest in adolescent health and women's health and around sexuality and around that and youth-friendly services. And the area of sexuality and being able to talk about sexuality is a bit of a minefield. There's a lot of sensitivities. There's a lot of history around horrible stigmatization and discrimination in the world of sexuality and gender. And so therefore language is always a challenge, and please be patient with me if I make mistakes, and please correct me if I do. So my information is not yet based on my own research. I'm quite interested one day to actually look at understanding better what's happening with sexuality in Mdantsane, for example, because we have no research, very little research on understanding sexuality in our populations. But the World Association of Sexual Health, especially the conference in September, was amazing, hosted from Cape Town. I'm going to be talking about the Global Advisory Board on Sexual Health and Wellbeing, which is a global organization. And then the WHO has got a very strong sexual and reproductive health and research section looking at these areas. So we're using a lot of the research and the language from them. Something I particularly like, came out in August of 2021 by the Global Advisory Board on Sexual Health and Wellbeing, and the recognition of these 3 aspects of sexual health. So what's been new, or what's actually been added, is this idea of sexual pleasure as a key part of understanding when we talk about sex, because ideally, that is what sex is hopefully supposed to be all about. We're assuming the odd person might be having sex for the sole purpose of having a child. That does happen, but the majority of sex is not happening to produce children. And hopefully the majority of sex should be happening for pleasure. And yet pleasure is almost never talked about when we're discussing sex with our patients or when we're discussing sex with our clients. But what's interesting, although sexual pleasure is something that's supposed to be happening in the privacy of your own relationships, for centuries, sexuality has been very much controlled by politicians, by culture, by society, who would say what kind of sex is allowed and what kind of sex is not allowed, what is good and what is not good, what is right and what is not right. So there's been a lot of superimposed external opinions on what sex is and who's allowed to have sex and what kind of sex they're allowed to have and who they're allowed to have sex with. So this has been, in South Africa, we have moved on. We're probably one of the most, I was going to use the word civilized, the most advanced countries on this front in terms of understanding sexual rights. But in the global world, as we stand today, there are still huge differences between different countries. So what is allowed to be done in London is very different than what's allowed to be done in Kabul, for example. So we're still struggling with huge political differences around sexuality. And in between all of this, we are trying to provide sexual health services. So there are even countries where you as a healthcare practitioner can be prosecuted for providing certain types of sexual health services. Even just telling a woman about a fertility in some countries is considered illegal. Providing services to gay people is considered illegal in some countries. So we have this intersection of sexual pleasure, sexual rights, and sexual health. And a lot of what I'm talking about is going to feature around those three. So where does it put us as family physicians? And actually, we also not just standing in our role as physicians, we are also people who stand within certain cultures, within certain societies, within certain backgrounds, within certain churches, and you will already have your own perspectives on sexual health and sexuality and what you feel comfortable with. And I think for me, there's not a contradiction in that. So as family physicians, we're going to be looking very much at patient-centered care. So I want to be respectful of whatever your own sexual preferences, orientation, or ideas are about sexuality, and at the same time being able to create a safe space for our patients. So we want to understand my patient's concept of sexual pleasure. We want to be able to respect and accept my patient's sexual rights. And we want to provide obviously relevant-based sexual health services, which we'll talk about today as well. So what creates healthy sex? So what is the sort of foundations of making sure people have good sex or great sex or happy sex? And that's not the Grey's Anatomy version of sex. And it has what we call sexual intelligence as these 4 components, which you'll notice is very similar to emotional intelligence, which has a similar 4 components. So first is being able to understand and reflect on your own sexual self. And we're going to be doing that today. Obviously, being able to manage and understand what your own needs and preferences are and being able to communicate those is the second part of that. And then obviously also once you're in a relationship, how do you understand what the partner's sexual self is, how they relate to themselves and sex, and being able to manage the relationships and the dynamics and communication of that sexual relationship. Sounds relatively simple. The biggest fall down on all of this is us being able to self-reflect and understand what sex and sexuality is. And it's extraordinarily how badly this is taught at school and how badly it's taught at medical school. So I mean, I still look, our textbooks still belong from 30 years ago. So what you have in front of you, most of you should have a seat. It's called Gender Jabber. If you don't have one, I've got some laminated colored copies in the front here. We're going to go through these 7 areas today as part of what makes up yourself as a sexual gendered being. And you'll see at the top 2 there talks about gender, the middle 2 there talks about sexual orientation, and the bottom 2 there actually talks about our own sexuality. So this tool comes from originally something called the Genderbread Man, which is a GAB tool from the Global Advisory Board. And it's been adapted by WITS RHI and some of our local organizations who's created Gender Taboo. And I have further added some of the sexual stuff that's come from my sex education background. There's lots of them available in different versions on the internet. And this is a great tool. I use it with adolescents. I've used it with my own kids. I use it with the teachers when I teach them. I'm using it today with you. But that's a great way when you're wanting to have a conversation with a patient to help them reflect on what's going on for them by using this tool. So we're going to start off, these are gender taboo. We're going to start off looking at biological sex. That's right here at the bottom. And biological sex is the sex you get assigned to as birth. So these are just terminologies. I'm sure some of you are already very familiar with this, especially the young ones. And it's what the midwife says at birth. Oh, it's a girl. Oh, it's a boy. Or oops, I don't know. Okay, so that is your women and your men, and then your other. So your other gendered under biological sex is to do with intersex. And South Africa has some of the highest numbers of intersex in the world. It's about 1 in 1,000, which is interestingly, of 1,000 births can be classified as intersex, which is almost as common as twins. And in 2016, South Africa at the United Nations also officially confirmed that doing practices on newborn, so deciding on the newborn, oh, I think this should have been a boy, or I think this should have been a girl, and doing a surgery at that point is considered harmful and abuse. So the idea is not that you choose for the child at birth what gender or what sex you think they're going to have to be. That decision they must make. And that intersex, there's a lot of rights now around intersex people saying, hold on, this is my gender. What if I'm comfortable with being exactly just this? So intersex is defined as somebody who the reproductive or sexual anatomy that doesn't quite seem to fit the typical definitions of female or male. And you can already there see how we actually struggle with this idea of trying to fit the whole world into this nice binary. This is men and this is women, because there's too many different variations and crossovers. The 7 characteristics we typically use for biological sex is obviously looking at the genitalia. So you can go and look at the chromosomes, but as you know, being able to say if somebody's XX or XY actually tells you very little about that person. Gonads, whether they've got ovaries, testicles, internal sex organs. It's not only about which hormones they make, but also how the hormones express themselves in the body, which is also interesting. And then your secondary sex characteristics. And you can just see from that already with a mixture of that, you can get a whole range of what we consider to be more female, more male, and more in between. What's much more important than biological sex, which for us as doctors, we just need to know which bits the person has. If they've got a uterus, I need to do cervical screening. If they've got a prostate, I need to do PSAs. The biological sex beyond that is not important. What's much more important is the gender identity, which is much more powerful and much more specific. So sex can be not so clear if it's male or female, but people usually have a very strong experience, or who do I identify with? So if you look at the top right-hand corner of your gender taboo, there's the gender identity block. And you can see there's 3 different options here. On the left side of the arrow, there where the note is on your pages, is if you don't identify with being female at all. And then if you completely identify with female, you're on the other end of the arrow there. Same with the male. I don't very much identify with being a man, or I completely identify with being a man, or actually I identify with other genders. And you can have a variety of mixtures. So you can get some people who strongly identify with both being male and female. So in the Native American tradition, there are Native Americans called Two Spirits. They're quite often the shamans in their groups, and they identify with both male and female very strongly. Or you can get people who don't identify with either. We'll look at some of the terminology in a minute. So identity has been with us since the beginning of time. And was brought out a statement to support gender diversity at their conference in 2021, particularly recognizing that person's sexual orientation, gender identity, gender expression, and bodily diversities require human rights protection. So there is a concern that a lot of these varieties that is part of normal human diversity, their rights are being massively impinged in some countries in the world. And one of the challenges with our transgender and gender diverse persons is that they have worse health outcomes and poorer health care access than our normal cisgendered key population, which I will do the definitions in a minute. So how many people are trans? We don't actually know. There's different things in different studies. We obviously have very poor information in South Africa. But the studies that we have, it looks like the percentages in South Africa is pretty much similar across the world. And it's sitting between 0.5, 1.3, yeah, so that's your confidence interval, but it sits between about 5 per 1,000 people are trans. So it's a small percentage of people. So sometimes people can go through school and you've never met somebody that's trans, but also a lot of people don't ever come out as being trans, are not clear about how they're experiencing their gender identity. And especially in a town like Mdantsane, there might be a lot of people who are struggling with these kind of questions and don't even have the language to express it in. So what's very clear now is we now have enough research and understanding of transgender as well as sexual orientation to know that it's a biological basis. You are born basically with it. Although gonadal sex is set up in the first trimester, during the second trimester, when the brain develops, gender identity is already determined by a range of different factors. It's partly nurture and partly nature. So when they look at monozygotic twin studies, there's about a 39% concordance for gender incongruencies. So some of it is genetically within how the brain is, and some of it has to do with the prenatal normal hormones. And what's interesting is when they look at the brains of somebody that's, say, transgendered, a transgender woman versus a cisgender woman, it's not that transgender people have a brain that is female, but their brains are definitely different than cisgendered male brains. So there is some different phenotypes in gender incongruence that's different than from our cisgendered compatriots. So what happened with our understanding our biological and trying to move away sexual health from political and cultural things, we've also had to rewrite our textbooks. So for example, in the DSM-4, the old DSM-4, it was called gender identification disorder. So it was treated like anorexia. But in DSM-5 in 2013, they have updated it now. And there's now a term called gender dysphoria. Gender dysphoria just means the psychological stress you experience from not being the same gender that you were assigned at birth. So, and the reason why they still have it in the DSM at all is because if somebody wants gender reassignment surgery, they need an ICD-10 code. And so gender dysphoria, the fact that they are extremely unhappy being in the wrong biological sex, the code will then come, will be the DSM code gender dysphoria. And the same with the ICD classification. So the ICD-10 used to be gender identity disorder, and now they're calling it gender incongruence. And again, the only reason why it was kept as a diagnosis or as an ICD-10 code is for gender affirming therapies in America specifically. And you can see that's very recent here. It's 2019 that it was actually adopted by the World Health Assembly, and that the World Health officially ruled that being trans or gender diverse person does not mean that you're suffering a mental disorder or that you have some pathology or some abnormality. And this is recent. So this is sort of the new frontier we were on. We were on this frontier 20, 30 years ago with homosexuality, and 50 years ago with female sex, where there were things that were still considered unacceptable. And we are now currently on that area. So in the world of gender, you as healthcare professionals, to be professional when we're looking after trans populations, we have to understand the terminology. So if somebody is, that is the midwife, it's a boy, it's a girl, the biological sex bit at the bottom of your page, we call that assigned male at birth or assigned female at birth. And then the transgender people is a definition, then is they have a gender identity that is different than the sex they were assigned at birth. So if somebody's a transgender woman, they will say, I am a woman, but I was assigned male at birth. So I've got the biological bits of a man, but I consider myself a woman, or I am a woman. And a transgender man, similarly, they were assigned female at birth, but they are a man and they live and identify and present in the world as male. So cisgender, for those of you who are still a bit confused on terms, is for people like I'm cisgendered, so I was assigned female at birth, and I also identify with being female. And then there are lots of new terms. So you can see here, you can mark yourself on all kinds of interesting places on those arrows. And therefore, say you get concepts like non-binary, genderqueer, gender fluid, is people who either don't identify with either of the sexes, so they're either a neutral gender, or they identify with both sexes, or they're happy to move between the genders in terms of how they present. So transgender population, just like men of sex with men, has been identified as a key population. And that is because they have increased risk of HIV, increased risk of mental health illness, increased risk of STIs. And the biggest reason for that is that because of stigmatization is that they are not accessing care. So this is one of our big challenges with our transgender populations, and similar to our MSMs, and still so, I think in our rural areas, our men who have sex with men, our gay populations are not going to present so easily at our clinics saying they are gay. And our trans people often don't come to the clinics because of the way they get treated by healthcare professionals. So we're now looking at gender affirmation as a pathway to improved healthcare for mental health, physical health, and sexual health in our transgender population. And so this is the exciting bit of thing that came out in October of last year. The South African HIV Clinicians Society published the first in South Africa, a gender affirming healthcare guideline, specifically for primary healthcare in South Africa. So it's been well established that access to competent and dignified gender affirming healthcare is not only safe, but also plays a significant role in improving measurable outcomes from transgender clients. And this particular guideline is very much evidence-based and gives very clear guidelines on how to set up gender affirming services. And they've got a very nice extended version that's very detailed on all the details if anybody's interested in that. And what the guideline looks at when we talk about gender affirmation, what makes transgender communities novel in terms of how we treat them is that a large part of their gender, their health, is people just simply accepting the gender that they identify with. So treating a transgender woman like you would treat any other woman is the most important thing you can do for them. And that we call gender affirmation. So that's a very simple thing we can bring into our practices. And they've done big studies on the healthcare professionals' attitudes towards transgender. There was a South African study that came out in KZN. And there was a challenge with nurses would say in the ID, no, you are male. In the ID, I refuse to call you female. I refuse to call you ma'am. I will call you Mr. I will call you by the name you were given as birth. So these are huge challenges for trans people then actually accessing care. So there's different domains on gender affirmation. The first is being able to use the name that the person has chosen, to use the gender that the person have chosen, and then pronouns. So for those of you who are not so familiar with the whole pronoun thing, it's quite fun to go and look that up. So if somebody's a transgender woman, assigned male at birth, their pronouns are obviously she or her. If they're transgender, if they're trans man, then their pronouns he or him. And if they are non-binary or gender fluid and they don't in either category, we're using what we call the singular pronoun they. So it takes a little bit getting used to, but it's just polite to be aware of these different definitions. Psychologically, we can affirm to make sure there are trans-friendly psychological services available for these patients, so training up our psychologists in those mental health services. And then, of course, there's quite a large side to the medical side of it. So, for example, they have now, the EML has, in the last 6 months, just approved gender affirming hormones, the use for hormones and gender affirming therapy for tertiary hospital and regional hospital use. We're still trying to get it into primary healthcare use. So for example, at CMH and FRERE, we have available testosterone and estrogen to use for gender affirming therapy. Surgery, of course, is very much further down that line. But it's also about working with voice, working with respectful and easily accessible services, and of course, all your health services. So PrEP, post-exposure prophylaxis, contraceptive services, and done in a way that is gender affirming to your client. And then legal, there's obviously a lot of issues around trying to change your name in a legal document. In South Africa, you still can't change your sex in the legal document unless you've actually gone through gender surgery, reassignment surgery, which not every trans person actually needs to do. There are people who are quite happy to have their biological bits and identify with a different sex. So that was gender identity. The next one on the other side is gender expression, which is something slightly different. So again, you'll notice there are different ways in how you can express your gender that might have absolutely nothing to do with the gender that you identify with or the biological sex you were born with. So it gets all wonderfully open and free. That's Jonathan Von Ness. He's probably my favorite celebrity in the world. They're non-binary, and you can see there, that's at the Emmys. I think that's probably for Queer Eye. They've got that lovely masculine beard, so that's gender expression that's quite masculine. And of course, the dress and those wonderful shoes is obviously very much feminine, feminine expression. So there's a mixture of, and pretty much what's lovely about gender expression is we're moving slowly away from the cultural ideas that boys should wear this and girls should wear that, and really start being free and expressing in any way. And being affirming and accepting of however somebody wishes to express is where we want to get to as a society, and rather than the raised eyebrows. So now sexual orientation, I think that you're much more familiar with, and it's just to remind us that sexual orientation is not the same as gender identity. So gender identity is how I identify, male or female. Sexual orientation is who am I attracted to? And they've now actually, we actually now differentiate also that not everybody is attracted mainly through sexual desire. We'll talk a little bit about that in a minute. So you can either be physically attracted to women, you can be physically attracted to men, you can be physically attracted to other genders, you can be physically attracted to all three. It doesn't really matter. And there's different also levels of that. So it's very useful when you do your gender taboo with a patient, just by doing this and giving them the options to put themselves anywhere on the chart already affirms the fact that there's no wrong. There's just a spectrum, and we're just figuring out where you are on the spectrum. So 1973, that's not so long ago, probably feel long ago for those in the back, the DSM removed homosexuality as a pathology. So up until 1973, being gay was still considered a medical disorder. And it was only removed from the ICD in 1992. I mean, that's very, very recent. And under South Africa's ruling National Party, they didn't enforce it so strongly in the last few decades, but until 1994, homosexuality was still a crime that was punishable by 7 years in prison. And that's not very, very recent in our history. So there was some amazing looks at, so now you're starting to know all of our LGBTIQA plus abbreviation. We've talked about lesbian, gay, and bisexual, so that's sexual orientation. We've talked about transgender, and which is about gender identity, intersex, which is about biological sex. Queer is a lovely term we can use for all of those as a group, and asexual, people who have no specific sexual desire towards either men or women. And this is just a South African study that was looking at the prevalence of LGBT population in South Africa. And the confidence interval there is, we think it's between 0.9 to 2.2% of people identify as being either lesbian, gay, or trans. So sexual orientation, South Africa's constitution was the first in the world to prohibit unfair discrimination on the grounds of sexual orientation. But the rest of the world, there are still many countries, and there are still death sentences for LGBT behavior in Mauritania, Saudi Arabia, Somalia, Yemen, Iran, Afghanistan, and Pakistan. So we still live in a world where there's extreme inequality in terms of what is allowed and what is considered acceptable. This is a wonderful recent survey that was done by the Human Sciences Research Council that was particularly looking at South Africans' attitudes toward homosexuality and LGBT. I love the title. It's called Progressive Prudes. And I just want to highlight this one. So 51% of all South Africans believe that gay people should have the same human rights as all other citizens, even though 72% feel that same-sex sexual activity is morally wrong. And I think in South Africa, we have that lovely, it's that lovely possibility that I have my own beliefs, I have my own religion, this is what's not okay in my life or in my context or in my cultural background, but I can still be accepting for the rights of others. And this is moving more and more. As time goes on, we're seeing more and more of that, people becoming more and more accepting of gay marriage, of gay rights, of trans rights, without them feeling that they're needing to compromise their own beliefs. Right, so now we've talked about gender, we've talked about sexual orientation, let's talk about actual sex. And I'm going to talk about two aspects of that. The one is sexual desire, and the other one is around physical intimacy preferences. So we're starting with sexual desire, and I'm going to have to explain those two terminologies. So when we talk about sexual desire, the question is, what is a normal libido? And do you have the right amount of sexual desire? How often are you supposed to be horny? That's quite important because in the DSM, there are definitions for something called female sexual interest disorder and male hypoactive sexual disorder to do with lack of interest. And in there, they define how often they think sexual desire should be happening. The problem, of course, with our sexual desire model is it's very outdated. And this is the one you still find in the textbooks. It's certainly no longer found in the world of sexual health and sexual and your sexual educational world in terms of research. But if you go into your schools, if you look at your media, If you look at your medical textbooks, this is still what we find. And there in the top there is Masters and Johnson. I'm sure you've all heard about them. And this is the classic Master Johnson Kaplan model of sexual response, which talks about sexual desire. So you have an innate sexual desire that arises. You get aroused, the arousal builds, you peak orgasm, there's all this tension that builds, and at the end of orgasm, there's resolution, and this is considered how sex works. What's interesting about this traditional model of sex is that it was based on a study done where they actually got couples to come in to their lab in, I think it was Virginia or somewhere, and the couples was linked up to all kinds of things, and then they had sex in this sex lab. And that is how all of these changes were actually studied. It was revolutionary for the 60s. I mean, this is before the pill was even approved for anybody more than a married couple. What was interesting is the people that they asked to come and volunteer for the study. So they had to be heterosexual, they had to be married couples, they had to be cisgendered, obviously, and the women had to be able to achieve an orgasm during sex, which we now know is a very small percentage of women actually have vaginal orgasms. So they actually selected a very narrow part of the population, and of course, also very white and American, and that's become the standard of how we measure sex. So the term that quite often is being, the assumption is made that human beings have something called spontaneous sexual desire, and that's based very much on what we see in heterosexual, cisgendered teenage boys. Is a good example of what spontaneous sexual desire looks like, right? So sexual desire gets defined as, for example, having erections, having sexual fantasies, masturbating, and having a sexual desire to purchase sexual activity, right? So boys, you can see there 85 to 94% of heterosexual cisgender teenage boys experience regular spontaneous sexual desire. For some reason, this has been set as the normal. So when we try and figure it out how good somebody's libido is, we want to know how often in the week do they masturbate, or how often in the week do they experience sexual fantasies. This model has been very much updated in the 80s very strongly by Dr. Rosemary Besson in her PhD. And then Dr. Emily Nagasaki has done amazing work around looking at understanding sexual desire, and they've coined a new term called responsive sexual desire. And it's interestingly how they started noticing when they were doing studies on cisgendered women, again, it's a select population, but they were looking at women and they were looking at sexual desire, and they were measuring it against this idea of you're supposed to get horny so many times a week, that most women had very low libido. So there was this whole thing that women just don't have as much sexual desire as men. And of course, what was misunderstood is that this desire is just triggered differently. So spontaneous desire is quite often visually triggered and is triggered by minimal stimuli in the environment. So very little might trigger sexual desire in somebody who has a lot of spontaneous sexual desire. But responsive sexual desire is very context related. So it's not that there is not sexual desire, but sexual desire waits for the right context, usually in whether it be in a loving relationship or whether it be in safety. We're going to talk a little bit about intimacy in a minute. But responsive sexual desire is found in the majority of certainly women assigned women at birth, but even in your transgender women, there's a much higher percentage of responsive sexual desire. So related around a context or a situation, which means they almost never have spontaneous sexual fantasies. They never or almost never are having a need to necessarily masturbate. So at one stage, there was this huge drive about why do teenage girls not masturbate? Maybe they are just suppressed and sexually confused and they've been given all the wrong messages, but maybe physically their bodies don't need to masturbate, and that's also normal and doesn't mean that they don't have sexual desire and is not going to be able to have sexual relationships. So this understanding of where one's at between spontaneous and responsive sexual desire, and when you explain that to your patients, I get a lot of aha moments on that. So where are you in terms of spontaneous desire and where are you in responsive desire? So the limitations of this model is assuming that all sex or all intimacy is always about sexual desire, but maybe there's more to intimacy than just sexual desire and that sexual cycle. The typical sexual myths is that good sex should be spontaneous, should always end in an orgasm. It's always the same as intercourse and always requires an erection. And actually, we're much more expanding our understanding of physical intimacy and what physical intimacy means for different people. So I've used the term your physical intimacy preferences, and the terms we quite often find is eroticism and nurturance. And I'm going to go through those two concepts in a little bit more detail because you'll need to explain them to your patients as well. So intimate bodily pleasure includes both sexual pleasure and something that I'm calling sensual pleasure. And both of these means that you're having a powerful bodily attraction to an intimate partner. So we're not just talking about emotional attraction. I like you and you like me, and we are close as friends and close as a relationship, but we do actually have a need to be touched and get the clothes off. But there are different types. So the one we all know, and this is the one that Masters and Kaplan was studying, is what we will call sexual pleasure. And that's that one that goes from desire, sexual pleasure to orgasm, desire, arousal, orgasm, you know, the little cycle that we've seen. So it always starts with sexual desire, and it's very much linear. So sexual desire is very much driven by specific hormones in the body, specifically testosterone. It focuses on orgasm, it's goal-orientated, it's genital-focused, and it usually wants to end with ejaculation. And it's slightly different in depending if you've got male bits or female bits. So male bits, erection, of course, increased blood flow to the genitals, increased muscle tension, heart rate, skin flush, all of that. Female sexual desire is trickier because we tend to have similar things like the clitoris swells, the increased blood flow to the genitals, etc. But there are something called dyscongruence, genital dyscongruence, where a woman in any sexual activity, even when she has feeling no sexual desire or might not even have be enjoying the sexual activity, the genitals might respond. So you can't use that as consent. Oh, but she was wet and therefore she was responding. It's a bodily reaction to something that is happening. So it's not so easy for female sexual desire. But this is called eroticism. So it is, and this is what the whole media world of sex is built on. This is what porn is built on. This is what your normal sort of vision is of what sex is supposed to be, the bursting through the doors and against the wall kind of thing. Sexual desire and this kind of sexual cycle is always driven by testosterone. So there's always testosterone involved, but interestingly, if you were to measure somebody's testosterone level, we're not going to be able to tell how much sexual desire you have and what kind of sexual desire you like. So it also has to do with how this testosterone actually expresses itself in different parts of your body and brain. Sensual pleasure is something different, and this is considered more of a cycle rather than a linear line. And it starts with sensual attraction. So I'm going to use teenage girls here. Apologies for being a bit binary as an example, because this is very much oxytocin driven. So just like your teenage boys has got a lot of testosterone, which is why we see a lot of spontaneous sexual desire. In our teenage girls, we quite often see a lot of oxytocin. And there's a strong physical attraction to either opposite or same sex, but it's the starry-eyed, weak-kneed, in rapid, you know, the watch any teenage rom-com and you find it's filled with sensual attraction. And the sensual pleasure, which is usually in the hand-holding or the kissing or the stroking of the hair, is all expansive, euphoric, actually relaxing. And it's very much in the moment. It's not goal-orientated. It's tingling is one of the words that came up. But this is very different experience in sexual desire, and it's not the same thing. It's got a different pathway. It's run through different hormones, and it has a different experience in the time. Now, the two definitely work together. So when we talked about responsive desire and spontaneous desire, quite often for people who have responsive desire, both men and women, it will start here. It will start with intense sensual pleasure. And the more sensual pleasure there is, the more touching and hugging and holding, the more better the chances are that it's going to go over into sexual desire and into the testosterone cycle. So the two are very much linked, but they are different. So sensual pleasure, because of its oxytocin mediated, is linked to feelings of intimacy, warmth, love. This is the ability to be vulnerable, respect, communication, affection. So it's got much more of these emotional qualities to it than your typical sexual pleasure. And there's a pleasure specifically from sensual touching. So the word they use for this is nutrient. So when you go and look in the books, you will have say people, oh, I'm much more into eroticism. And then you have some people saying, no, I'm much more into nutrients. Orgasm is not the end and the all for me. So again, oxytocin is always involved in sensual pleasure, but measuring oxytocin again is not necessarily predictive of where somebody's at. And so again, one must watch out to not get too binary, although a significant amount of men or assigned male will have more of this eroticism side, and a significant amount of women would have more of the sensual pleasure side. There's still 20–30% of women that might have more sexual desire rather than sensual pleasure as their preference. So again, there's a range. And what's interesting about this is that this can change. It can change over time. It can change with what's happening in your life. It can change depending on the relationship you're in. So if we start putting it together a little bit, you can think about some people have more spontaneous desire and some people have more responsive desire. And some people have more of a preferences for eroticism, kind of physical intimacy. It's all about the orgasm for me. And some people might have, oh, well, it's all about the cuddling and the holding hands and the stroking and stuff for me. And in here, all these blue dots are all your variety of how different people might relate to sex. That's get interesting, because when we get into the sack with somebody, there's the assumption that we're all basically the same, and if we're not able to communicate where we are sitting on this, we're going to have a lot of confusion. So yeah, some of you will remember this, my favorite examples, very binary example, but that's our teenagers. They're 18 years old. They've just had their matric farewell and they've decided it's time. And this is a cisgendered 18-year-old couple. My boy here, I've put in the very top left-hand corner, a lot of spontaneous desire. It's all about the orgasm. Where our girl is here in the bottom right corner. She's got strong responsive desire and she's got a strong high level of nurturance, which means she is very attracted to this boy. And the kiss is just the best thing ever. And they're on the couch and it's all wonderful. The challenge is what she's experiencing might not yet have flipped into sexual desire. She might still be sitting on a very high level of this nurturance, oxytocin, and expansive, enjoying what's happening. But of course, if they have not communicated and if they've had the kind of sex education I've had, they're both confused about what's happening. So the guy is assuming she's horny because he's horny. She is not sure what's going on because in all the movies she's seen, this is now supposed to end up in sex, right? She's 18, this is what's going to happen. And she's assuming what she's experiencing is sexual desire because she's never masturbated. She's never experienced much sexual desire in her life because her body doesn't work like that. Now, with sexual desire and spontaneous desire and with the genitals become very much awakened. So in the boy, it's all about genitals, right? Boy's biggest dream is just grab my dick and I'm happy. The girl, the genitals are not yet awake. They're not yet engaging because they're not yet on a sexual desire cycle. So the classic thing in the movies is the guys, the hand starts creeping up the skirt, right? Because he's going where he thinks she would want him to go. And now the confusion happens. And there's two things that can happen in this scenario. The one thing is that she allows for it all to go on because this is what's supposed to happen. And she's supposed to now have sex. And then I've had teenage girls in tears in my consulting room that they don't like sex, or the sex was just not great, or they can't get an orgasm, or they don't know what, but it was just not nice, or it was painful, or something didn't work. And that is because they didn't understand that they were not yet there. They could get there, but they weren't there yet. The other thing is she feels, no, this doesn't feel right. I'm not comfortable with the legs closed shut. She pushes him away and now they're both confused. And he's like, well, you've been giving me all the signals. I was thinking you're really into this. She's wondering if there's something wrong with her. She's getting called for, and now you have all these sexual translation issues. So the poor guy gets accused of only wanting one thing, as if that's wrong. That's perfectly normal in his body. You get slut shaming. So girls who do have a lot of spontaneous desire and has got no problem with sex, they get called names. Cock teaser, if the girl pulls back after she's given so-called signals. I thought you liked me, therefore we should now have sex. And feelings of inadequacy on both sides. The guy's feeling, well, I've done something wrong, why is she not into me? Or the girl feeling, something's wrong with me because I'm not right. So this is simple communication stuff that is often just based on proper understanding of how sex works. So if you think of sexual diversity, our sexual pleasure is affected by our sexual desire, our experience of our sexual pleasure, but it also is affected by our age, our life phase, our life circumstances. The boy at 17 is not the same man at 45, is in a relationship with several kids and has a different relationship to intimacy and sexual desire, the kind of relationship you're in, depending on your sexual orientation, your gender identity, who am I and who do I like being when I'm having sex? And then of course, medical and health conditions and all of that also plays a role. We're not able to completely communicate all of this, we're not going to be able to have good sex. So the first part we talked about is just doing a gender taboo on ourselves. And when we start talking about relationships and talking about sexual pleasure in relationships, I love this, is also part of the WAS definition of sexual pleasure. Self-determination, consent, safety, privacy, confidence, and the ability to communicate and negotiate sexual relations are key enabling factors for pleasure to contribute to sexual health and well-being. And it's to get everything I've just talked about is about this, about being able to understand who we are and accepting our own sexuality, being able to understand and accept your partner's sexuality. So what's very powerful, and I always encourage my teenagers to do this, is that each of them fill one of these in and they talk to each other about where they're at before they have sex. Sounds very boring, but it's actually quite fun. The most important part is communication, and this can help with that communication process. And then my big passion is about true consent. So our biggest challenge probably in the world of sexual pleasure is consent. So we live in a world where there is expectations of my sexuality is like that, and you should please or accommodate that. And sex is not a compromise. It's not a, oh, you do this for me and then maybe I'll do that for you. Sex is always about finding the common ground. So when you have this very diverse sexual experiences, you'll always be able to find overlap and have great sex. That's always possible, but you cannot expect somebody else to compromise or negotiate on what they're comfortable or not comfortable with for your own sexual pleasure. So sexual pleasure is about finding that, and true consent is that both people are happy with whatever is happening. Great. So sexual health, I'm just looking at time. I'm going to run through just a couple of the slides. This is all very, moving on to the more dry stuff. It's all in the EML. I want to just highlight a couple of things around sexual function problems, because I want to spend 5 minutes on just some of the language we're going to use in our sexual health consultation. So the important thing to realize is that sexual problems are prevalent. This is a South African study, but that most people don't seek for help. And how we define sexual dysfunction also gets interesting, because you've got all this diversity, and the main thing that the DSM has done to try and bypass how we define something as abnormal is it says, well, does it cause sexual distress? If it doesn't cause you sexual distress, it's fine. So that's currently how they're defining sexual dysfunction quite often. But we have very little articles on sexual dysfunction. So that's all the articles we have, proper research articles on sexual dysfunction in South Africa. And in men, it's always about erectile dysfunction. Nobody ever looks at anything else. And then there's quite a little bit about sexual dysfunction in terms of comorbid conditions. So classifying sexual dysfunctions, for male sexual dysfunctions, either disorders of erection, disorders of ejaculation, or this disorders of desire arousal. So it's quite interesting when you talk about desire arousal, sometimes a lot of it is more got to do with people's understanding of arousal than the actual problem. And in women, there's again, female orgasmic disorder and female sexual interest arousal disorder. You can understand very differently when you start looking at variety. And then in women specifically, genitopelvic pain penetration disorder, the old vaginismus was included in that. So those of you, that's the DSM-5. We're not going to cover DSM-5 now. So the important thing with the DSM classifications of sexual dysfunction is that you have to exclude a whole lot of things to actually, because the DSM, for goodness sake, is a psychiatric manual. So it must be not related to, depression or psychosis. It must not be related to substance abuse. It must not be due to a medical condition. It must not be due to a horrible relationship. It must have been there for longer 6 months, and it must cause sexual distress. And actually the DSM definitions are becoming less and less useful. Most of sexual dysfunctions either is in us being able to properly help people communicate around sex or around excluding physical causes that we need to address. So male sexual dysfunction, it's always all about the erection most of the time when they talk to us about that. And the most important thing for us to realize is that in itself, it tells us it's an important issue in our cardiovascular risk patients. So for patients with metabolic syndrome, there are similar organic or erection dysfunction. You know, we obviously often talk about peripheral neuropathy and we talk about chronic kidney disease. We talk about the hypertension, but actually your erectile dysfunction fits into part of that package. And our lifestyle factors, the same lifestyle factors that is built, you know, that is part of that cardiovascular disease component is also contributing to our ED. So whenever you're looking at erectile dysfunction for a man, you also have to assess for metabolic syndrome and all these risk factors. And whenever you are looking after somebody with all of these conditions, you should be having a conversation about erectile dysfunction. And that we don't do that often. How often do we ask our diabetics how things are going down there? So the management is, this is from our EML. And your biggest thing is to make sure there isn't a medical simple cause that you can simply first address. So you're going to take your medical and psychosexual history, and you're going to try and see is there an androgen deficiency possibly. So there's a nice little chapter on androgen deficiency in the EML. And you're going to look for like gynecomastia or testicular atrophies, any androgen deficiency. So you want to then look for testosterone. Check what medicines they are on. Your antidepressants are not helpful. And then very importantly is addressing those cardiovascular risk factors and life measures. We don't have specific measures in the public sector, and you can't use testosterone to treat erectile dysfunction. You can only use testosterone if there's an androgen deficiency. Testosterone is not going to do anything for your erection, okay? So I'm not going to cover androgen deficiency. You can look it up in the EML if you've got a patient you want to work up. But what makes it more complicated is that if somebody is struggling with erections and then they get worried about having erections, then that's going to make it worse. So quite often it's always combined with some psychogenic factors by the time we see patients. So I've just got a slide. So what we do here is after you've done all of that, you can prescribe in private. You can give your men a private script for Viagra. We've got 3 drugs. There's Viagra and Cialis. I think Cialis is a little bit cheaper that I can see in South Africa. I'm not going to cover the mechanism here, but basically it unlocks the gate, but the gate still has to be opened in terms of blood flow to the penis, right? So it's not that you take the tablet and bing, you get an erection. So you have to take the tablet about an hour before sex, and you still have to be sexually stimulated. There still has to be some sort of visual or sexual stimuli for the whole thing to work. So it's important to counsel the men correctly, because now he's nervous, he takes his tablet and he waits for it to work before he goes and calls the missus. That's not going to work. Call the missus first. Can work within 30 to 60 minutes, but it varies on different people. And then the costs, they're expensive. So the problem with that is, so your actual Viagra is 70 to 100 Rand per pill. I've noticed online you can buy Cialis at 19 Rand if you buy like 100 at a time. I'm a little bit nervous about stuff you buy online. So I'm not sure, we'll have to just double check what's happening. I'm sure there are chemists and things where one can get. I don't know if anybody knows where you would send your men for a cheaper script of Viagra or Cialis.
So it was 120 odd Rand for a pack of 10 at the
Okay.
pharmacy.
Thank you. Which one?
Viagra.
In Kanduli, okay. I'm sure they would, yeah. So it's probably good to know something like that, because it's
there was a lot of men that came for their refills.
Yeah, so once they hear, then they will hear from their friends, and quite often when they arrive, quite often men will actually bring up, I would like to have this tablet that I've heard about. Female sexual dysfunction is a whole different, and it's interesting with female sexual dysfunction that when Viagra came out, how excitedly they tried to fix female sexual dysfunction using Viagra. And you can see with this why that did not work. So Viagra, and there's no magic medicines that's going to suddenly create sexual desire and change a woman from responsive sexual desire to spontaneous sexual desire. And a lot of it is being able to understand context. So that is why counseling is so important, in being able to look at all the different factors that creates context around sexuality. For us as doctors, it's very important to look at what medical conditions we need to exclude, and particularly looking at counseling our women also around aging and how sexuality changes, but also making sure there's nothing medically that's interfering. So I can send around this article. This is some of the medical conditions, just to notice that things like diabetes and hypertension can also affect things like sexual desire, changes things, but obviously Parkinson's disease. There's a lot of basic illnesses where arthritis, any illness that gives you pain or discomfort is going to influence your sexual function. And probably most importantly is to watch out with the drugs that we prescribe. So any hormonal preparation, all of our contraception can, not always, but may affect sexual function. And our SSRIs are a big culprit, and that's problematic. So that needs to be discussed with the woman, because sometimes people are put on antidepressants and now you just have them on antidepressants, and it's assumed because they're depressed, they're not going to want sex anyway. But as the depression changes and as they get better, they might get to a place where they want to get back into sexual relationships, and there needs to be an understanding of the drugs that they're on. So let's talk about sex. There's a lovely project called the Pleasure Project, which particularly looks at sexual health programs and how we use pleasure language when we teach sex or when we discuss sex with our patients in sexual health settings, and looking at rights, respect, consent, and all of those kinds of concepts. And as I've mentioned at the beginning, as doctors, our own cultural, religious, political perspectives might not always be the same as our patients. So the only superpower you have, or the main superpower you have as a doctor, is this ability that we can stand strongly with our perspective and yet be completely accepting and affirming of another one's choices. And I think South Africa is a particularly good example of that. As South African, I think as a diverse population, we have learned this ability to still be strong within ourselves and still be able to look after somebody that might have a different sexual lifestyle than our own. So the biggest thing I want to encourage you today is to talk more about sex. So most men are not going to bring it up, and you need to find opportunities to bring it up. So obviously in any sexual health consultation, you need to bring it up. So if they're talking about STIs, you need to talk about sex. But you can also bring it up in aging patients. Well, how's sex going? You know, how's that going? How's things going in the bedrooms? Remember your key populations, definitely your adolescents. Have you thought about sex? What's happening with sex? How's things going with sex? And not to forget our patients with chronic diseases. Women may be raised a little bit more often, but most people expect the doctor to raise the topic. So you need to gain a little bit of confidence in talking about these topics. So here's the kinds of questions you can ask, and you can have a list and just get used to asking them. When you see a patient with an STI, have you had sex in the last 3 months? And then routinely, do you have sex with men or women or both? Just get good at asking that and being able to ask it in such a way that the person feels they can answer you and that you are not judging what that answer is going to be. So as soon as you make an assumption that, oh, do you have a girlfriend? There's no way he's going to say, well, no, I don't have a girlfriend. Actually, I've got a boyfriend, you know. Then you can ask about partners. Again, how many partners have you had in the past 12 months or 3 months or 2 months? If you're not sure about gender, ask people, what gender do you identify with? Or a really cool way to ask is, which pronouns do you prefer? So if you've got somebody where you think, oh, maybe they're gender fluid or non-binary, or you've got somebody like Jonathan who walks in with a beard and a dress, then you can just say to them, which pronouns would you prefer? And that will help you clarify where they are on the spectrum. And you can take your sexual health history taking to the next level when you feel a bit more confident. So to actually ask teenagers, I often ask this question, well, do you enjoy sex? Do you like sex? Have you ever had sex even when you don't feel like it? So this is around consent, okay? Being able to talk to girls, especially about consent. How often do you feel like having sex or have fantasies about having sex when we're talking about responsive desire? And what is the best part for you, the cuddling part or the sex part when you're talking about eroticism versus nurturance? So my last slide, a key principle in effective communication is just to avoid making assumptions. Don't assume their sexual pleasure is the same as yours. Don't assume you know their gender identity or sexual orientation just by looking at them. Don't assume you know how the person wants to describe themselves or to their partners. And don't assume that all your patients are heterosexual and cisgender. Thank you very much. I'm hoping this will inspire you a little bit in some of your consultations this week. But certainly we are looking at, I'm looking in the next year to set up a project of a gender affirming service here at CMH. And we will be looking at running through the HIV Clinicians Society actual workshops on gender affirming therapy. So that is in the pipeline for those of you that have an interest in working with key populations. Thank you very much.